All right, good afternoon, everyone, and welcome to our October webinar, The Psychology of Pain, Evidence-Based Tools for Healthcare Providers. My name is Ari Spence. I'm the Education Lead at Pain BC. And now to introduce our presenter. So Dr. Dayna Lee-Baggley is a registered clinical psychologist in Nova Scotia, British Columbia, Ontario, and Alberta, with reciprocal agreements for clients in Atlantic Canada and Quebec. For close to 15 years, she worked as a clinical health psychologist for medical surgery and cancer care units at the hospital. She has taken all this experience to open Dr. Lee-Baggley and Associates, a virtual health psychology clinic offering clinical interventions, training for healthcare providers, and educational courses on health-related topics. She holds an assistant professor appointment at the Department of Family Medicine and a cross appointment in the Department of Psychology and Neuroscience at Dalhousie University, and an adjunct professor appointment in the Department of Industrial and Organizational Psychology at St. Mary's University. She is an internationally recognized trainer in acceptance and commitment therapy. So please, everyone, join me in welcoming Dr. Lee-Baggley for today's presentation.
Awesome. Well, thank you very much for having me. I'm going to share my slides here. I already had the introduction. I did my master's and PhD at UBC in Vancouver. So I'm actually now in Halifax. So of course it's much later in the day here, but still by an ocean. So it's okay. Okay, so I'm going to be talking about some tools that healthcare providers can use to help with pain and chronic pain. So first of all, we just need to talk about what the pain system is about and our understanding of chronic pain. So the way we think about pain is that it's supposed to be kind of an indicator of tissue damage. And so if you have more pain, there should be more tissue damage. If you can't find tissue damage, then there shouldn't be pain. But that's not actually the way the pain system works. And so using that as, our bias around what pain is, the cause of pain, ends up causing some difficulties along the way because that's not really the way the pain system works. The pain system is really more of an alarm system, and it's to indicate that there are problems. And it's more like an electrical system that is sending signals to different parts to indicate that there might be danger or threat or alarm or damage. And so we get often patients sort of getting this impression that somehow the pain is like all in my head. And the thing I like to say about this, which is actually everything is all in your head. You can't see something, you can't taste something, you can't touch something until it gets processed by your brain. And that's also true of pain. That doesn't mean it doesn't exist. Again, if we use this definition of pain as a reflection of tissue damage, then that becomes, we can't find the source of the pain. But if it's an alarm system, an electrical system in the body, then it absolutely can be occurring even when there's no tissue damage. And we can sort of make use of the fact that our brains process pain in adaptive ways. So if you've ever seen an athlete run with an injury, keep going with an injury, or we see soldiers doing that when they're injured, this is the ability of our brain to modulate our experience of pain. And basically, our brains are capable of withholding the pain signals so that we can save ourselves and get somewhere safe, right? You don't realize that you're in pain until you kind of relax. And that is our brain's ability to change our experience of pain. And so rather than sort of seeing that as like, this is somehow a made up thing, we should make use of that system to help people cope with chronic pain. And so we can sort of understand chronic pain as being a false alarm. That electrical system is going off and indicating that there's threat or damage, even though there isn't a threat there. And so it's sort of like that electrical system misfiring. And so again, I think it's helpful for us to understand how our brains work so that we can, again, make use of how these systems work to come up with better solutions. Part of our brain responsible, for emotions, automatic thoughts, learning, memory, appetite regulation, and pain regulation, just referred to as our survival brain. Gives you excellent advice if you are a cave person and your life expectancy is 30 and the kinds of threats you deal with are bear attacks. this system also functions automatically and unconsciously. I think it's really important to recognize that we can do things that influence this system, but we can't directly control this system. And that gives us information about what we should be doing, to manage some of these issues, is we don't want to target something that we actually don't have control over. This is, of course, our survival brain is where pain is sort of regulated. And it's, in a sense, having chronic pain is kind of like having our survival mind on fire. And so it's sort of like that alarm system is constantly indicating that there is danger or threat. And so that is super exhausting, for one. And it also compels us to try to rest. And of course, resting in response to an acute illness or injury could be a really smart idea. If you break your leg, just resting and not moving it will help it heal on its own. And so that system then gives us all of these messages about you should rest, and so that's why it's a natural response for people with chronic pain to, reduce their activities. We know that in chronic pain that ends up causing problems, because then they also are struggling with like their muscles not moving enough and atrophy, and then they have pain caused just by moving around when they don't normally use those muscles. But it's a natural response to try to rest. And things that come out of our survival mind are often really compelling, right? They're designed to not be kind of debatable, but really convincing. And so this ends up being our distinction between hurt versus harm, which is that it could cause pain, it could hurt, but it doesn't necessarily indicate you're causing more damage to the system. It could just be that false alarm that's going off. The other relevant part of our brain would be our prefrontal cortex, or our frontal lobe. And this is the location of executive functioning. So things like starting behavior, stopping behavior, basically controls behavior. It's where decision-making happens, willpower, self-control. And unlike our survival mind that's kind of always working, our frontal lobe is like a battery. And so we will wear out that battery as we use it up. And that's why things like binge eating, for example, are more likely to happen in the evenings compared to the mornings, because we've used up that battery of self-control. But our survival mind likes short-term quick fixes, which of course food offers us. This is also, in part why all of us are so super exhausted from living through the pandemic and the crazy post-pandemic world we also now have to contend with. And it's kind of like there's no frontal lobes anywhere, right? So it's sort of like when you have a cell phone that the battery won't charge properly, or it just drains really quickly. Our frontal lobe batteries are just exhausted, and they keep having to be used up by all these like new stressors that we face. And that's partly why everyone is so exhausted at this point. So I'm often saying no frontal lobes anywhere. So basically, when we're talking about chronic pain or any kind of chronic disease, we need to think about that battery management, right? And how we're making use of that battery. So we do definitely want to make sure you're charging your frontal lobe, right? And a recharging activity is something that makes you feel more energetic at the end than when you started. So common ones for most people would be things like sleep, eating healthy foods, staying hydrated, physical activity, being in nature, and social connection. But there's also individual differences. So for an extrovert, being with other people could be recharging. For an introvert, that might be draining. There's also probably an optimal amount. So going for a walk for 20 minutes might be recharging, going for 6 hours might be draining. It's not necessarily the same thing as a healthy habit, right? So if going for a walk makes you feel angry and irritated, then it's not a recharging activity, even if it's a healthy habit. We're actually looking for things that make you smile, things that make you feel a bit lighter, make you feel a bit more energetic. Again, I don't think anyone's getting to full battery charges anymore, but we want to be mindful of this. If you think of how often you charge your cell phone, we should be charging our own battery with a lot more intention. So one of the big things that we work on with people with chronic pain is pacing. And this is about battery management again, right? There is a fixed amount of battery. That battery is fixed. We want to make sure to recharge it, but it's a fixed amount. This kind of message we get in our culture is just try harder and you can do more. It's not really true. There's a fixed amount. And so recognizing that there's a fixed amount and that there is less energy if you have a chronic disease or you have chronic pain. Part of that battery is dealing with your caveman brain that's on fire. And so there is less energy overall in your battery. This is also referred to as the spoon theory, that basically you have a certain number of spoons and how are you going to make use of them? And so pacing, what happens for people with chronic pain is that when they have a good day, they sort of have this experience like, oh my gosh, when am I going to have another good day? I better do everything I can while I'm having a good day. And then they kind of overdo it, right? And then they pay for it. And so then they have a bad day. And you end up on this boom and bust cycle. And it also makes life really unpredictable because you're kind of like, well, uh, what's my pain level today? Because that's going to decide what I can get done today. Pacing is the idea of having a certain amount of activity that doesn't change regardless of whether you're having a good day or a bad day. And so it's trying to keep that activity level constant, even though your pain will still be going up and down. This actually makes us more reliable over time, more consistent. Often people with chronic pain will say, like, nobody invites me out anymore because I always have to cancel at the last minute. And so it makes you more reliable because you're keeping the activity constant, regardless of whether it's a good day or a bad day. This overall amount of activity is probably less than what you can do on a good day. And it's probably less than what you could do before you had chronic pain. And that's what's hard about doing it. It's also really challenging for people to hold back on a good day. That tends to be the issue. People will kind of push themselves a bit on a bad day, but holding back on a good day. So when you feel great, when you feel like you could keep going, and when you're worried about whether you'll have this much energy again, we're telling you have to stop. And that actually is like the challenging point and management is holding back on a good day. But it allows people to feel more empowered. They know they can get this basic activity done. They're not kind of deciding what they can do based on their pain. And that makes us feel more in control. And so this is about, again, using your battery wisely, the ability to hold back on a good day to save that battery for the next day, right? And then thinking about that those batteries as a fixed amount. And so how are you spending your energy, right? And is it on the things that matter most to you? I totally understand that things like laundry have to get done and like dishes have to get done. But it does break my heart a bit when what we're working on with somebody is like to do their laundry. I would rather that they're using their battery for things that are most meaningful for them and that are things only they can do because their battery is less. And so you want to spend it on the most important things. And so, what are the things that only you can do versus what are the things that anybody could do? So, there are real life demands, of course, that get in the way of this notion. For example, if you have small children or other demands that don't allow you to pace, one of my clients is like, my kid doesn't care if I want to pace or not, right? They're just telling me what I need to do. And so our other battery management strategy is about building a village. And so asking for and accepting help becomes a really important behavior to be able to do when we have a chronic disease or when we have chronic pain. And this is about building a modern day village. I often say it takes a village to be well. And so there's a couple of things about a modern day village. One, we're, kind of artificially creating it, but that's also because it's actually hard to find things in our culture, like a community in our culture. There's lots of institutions and systems that kind of prevent us from building community. But we want to make it more than your biological relatives, right? And I will often say, if your whole village is biological relatives, technically that would result in inbreeding, and that's not a good thing. We're actually trying to invite other people into our village, other people that might have different skills or different abilities or different knowledge to like help us with the condition. We want to probably rely on technology. It's always better to meet in person, right? But it's definitely better to meet virtually than to not meet at all. And for lots of people with chronic disease and chronic pain, their worlds actually have opened up a lot more because so many things are now virtual that they can take advantage of. We're likely to have different parts of our village. So your work friends might never meet your church friends, but they can all be parts of our village. And it's also really helpful to have some part of your village, which is people who understand what it's like to live with chronic pain. And so patient advocacy groups or joining those kinds of support groups so that there are people in your world who do just get it. We definitely should think about healthcare providers being part of our village, right? They are part of the people that help to keep us well. And then for people who can afford it, which obviously isn't everyone, but for people who can afford it, sometimes you want to pay people to be part of your village, and that's okay. It's not kind of an indicator that you're not good enough or that you should be able to have a family member do this for you. I pay, a babysitter to watch my kid, and that's a great use of my money so that I can spend it on the things that matter most to me that only I can do. And so when people have that, when it's available to them, which of course isn't always, it's a good use of your money to spend it on services to free up your battery for the things that are most important to you. So when we talk about chronic disease, there's a few, coping things that we want to highlight. So there are some different ways of coping, different types of coping. So one type of coping is problem-focused coping. And this is very effective when you can make the problem go away, when you can make the stressor, when you can eliminate the stressor. And many of us use this in our day-to-day lives. There's an email you have to send, there's a report you have to write. Those are all technically solvable problems. Once you send the email, it's done. Once you send the report, it's done. Of course, in modern life, there's something else to take its place, but they're technically things that you can fix and you can make the stressor, go away. Emotion-focused coping is effective for problems that can't be fixed and that won't be going away. And it's about dealing with the emotions that arise from an unfixable problem. And so by definition, a chronic disease, chronic pain is a problem that you can't fix. It's a problem that we need to manage. It's a problem that you definitely want to spend time and effort managing. But it's not something that will go away. And so when people get caught up in problem-focused coping, thinking that it will eliminate their pain or control their pain, we get into trouble because that type of coping just doesn't work well for these kinds of problems. Many people actually don't have a large repertoire of emotion-focused coping skills, in part because they often haven't needed them up until that point. And so it is often about building a new set of coping strategies that you didn't need before in order to deal with a health condition or chronic pain. And then lastly, relationship focused coping is about managing, preserving, and maintaining relationships during stressful periods. And that's about sort of thinking about it as an us or a we rather than just me, and making kind of keeping investments in our relationships. And we know that those relationships are really important, again, to our well being. So when we think again about how our brains work, again, I always like to know this so that we can come up with better and more effective strategies. So our brains can be oriented to a threat focused system. And this is about protection and safety seeking. It's responsible for the fight, flight, or freeze response associated with feelings like anger, anxiety, and fear. And it actually gives us tunnel vision. And what that means is we start to feel like we only have option A or B, A or B, that's all I've got. And the threat focused system does this to us on purpose, because if you're facing a bear attack, that is not the moment to brainstorm 150 different ways to deal with a bear attack. You need to just pick one and go with it. And so we get tunnel vision when we're stuck in the threat system. And we often have these conversations, like, could you try this? No, that'll never work. Could you try this? I tried that before, it doesn't work. Where they're, again, kind of feeling like they don't have many options. Again, pain is part of the threat focused system. This is it's telling you that there's danger, that there's an alarm, there's something that you need to be watching out for. And so it is activated as part of this system. There's also a resource-focused system, which isn't as important for our discussion, but it's associated with wanting, pursuing, achieving, and consuming. It's very activating, associated with drive, excitement, and vitality. And then there's a social focus system, again, when we think back to the importance of relationships. And this system is associated with safeness and kindness, about us feeling soothing, content, safe, and connected. In this system, when we're in this system, is actually when we are our most creative. It's when we're the most courageous, when we're most willing to go outside our comfort zone. And this is again, it actually opens up our world versus the tunnel vision. So when people are in this system, they naturally come up with new solutions, or they think solutions are viable in a way that they didn't before. So sometimes patients will say like, oh, well, how about this, this idea? And you're like, yeah, I think we talked about that last week. But if they were stuck in the threat system, they couldn't see that as a viable option. When they're in the social focus system, then that becomes they naturally kind of think that that's viable, and they're willing to try new things that are outside of their comfort zone. So this social safety system, it's very hardwired into humans. And humans, of course, are like the most social creatures on the planet. It says something about human nature that solitary confinement is a form of punishment, right? All we've done is take away social contact. This is also, hardwired into humans because of a biological necessity, which is if you watch other mammals being born, they are much more functional at birth. So if you watch like a giraffe being born or a horse being born, like within minutes they're standing up, and within an hour they're ready to like run with the herd. How about human babies? How long does it take human babies to be able to run with the herd? Right. So human babies are actually born incredibly more dependent than other mammals. And studies show that human babies actually don't catch up to other mammals until about 18 months. That's when they're about the same as when other mammals are born. And so, uh, and there's lots of different reasons for this. Part of it is that our large brains, there was an advantage to that. But the point at which babies are born now is kind of the last possible point that you can get that big skull out the birth canal. So in a sense, they're born too soon. But it also gives a really long developmental period for babies to learn their environment and to learn skills. And because humans pass down those skills through generations, and that's what allows us kind of to evolve more quickly is through what we call cultural evolution rather than genetic evolution. You need these long developmental periods so that you can learn all these new skills and adapt to your environment and learn kind of the rules of your culture. But the trade off to this is that humans are born incredibly more dependent than other mammals. And so you need a system to make sure that these babies are being cared for, literally for the survival of the species. If you don't get this right, the human race does not survive because human babies don't survive on their own. And that's where that social safety system comes from. It's also part of like the attachment system in humans. And it's hardwired into humans to feel better when we're connected and to feel distressed when we're disconnected. And that's this system in action, which again is a life-saving system. And it's part of our survival mind. It's not part of our logical kind of part of our brain. And so again, this social safety system is associated with emotional regulation. We're hardwired to experience positive emotions, to feel comforted and calm when this system is activated. And so deactivating that threat system and getting people into the social safety system automatically results in a different experience. Because again, making use of like our amazing brain that can help us experience different things. And so when people have that social safety system engaged, it actually changes our perception of the world. And so, for example, they have studies where they have people stand at the bottom of a hill and estimate how tall the hill is. And if you're standing there with loved ones, we will estimate the hill as being less than if you're there all by yourself. They have ones where they have people carry a backpack and estimate the weight of the backpack. And if you're there with loved ones, even though they're not going to help you in any way, we will estimate the weight of the backpack as weighing less than if you're there by yourself. Then they have studies where they have people in a functional MRI machine and they administer a standardized shock to their toes. And so you can see the pain receptors of the brain light up on the functional MRI. Basically, if you're holding the hand of a loved one, your pain receptors do not light up as much as if you're there by yourself. Now, if you're holding the hand of someone you have a distressed relationship with, it actually is worse than being by yourself, right? This is when we have that social safety system engaged. That when we have those safe, trusting relationships, the obstacles don't seem as big, the burdens don't seem as heavy, and the pain doesn't seem as bad. It's not because we've fundamentally changed anything. It's because we've tapped into this hardwiring of humans to feel better when we feel connected. And it's actually really interesting, these studies about the fMRI and pain, which is that, the neuropsychologist that did this study pointed out that the default setting in the brain is actually that our brains expect that when we're in pain, that there's someone else there. So it's not so much that adding a hand decreases pain, it's technically that our brain expects somebody else to be there with us. And when that person is not there, our pain goes up, which is just to say that the default setting of the human brain is to assume that if you are in pain, if you're suffering, that somebody is with you. And when that isn't there, it makes the situation worse, the experience of it worse. So this is also related to polyvagal theory, if you've ever heard about this, but it's basically that threat system, which is responsible for fight, flight, and freeze, can be deactivated by activating the social safety system or the social engagement system. And again, we have hardwiring through different, biological mechanisms to activate that social engagement system in a way that's different for mammals than invertebrates, for example. And again, it activates a sense of calmness, groundedness, compassion. These things sort of happen automatically when that social safety system is engaged. So I'll give a few tips about how can we activate this social engagement system as healthcare providers. So the first point we're going to stop at is about compassion. And I like to distinguish toxic positivity from compassion. Toxic positivity is sort of this, you have to think positive, or you should be thinking positive, or why are you thinking so negative, or just get rid of your negative thoughts. And it's sort of like compelling someone to have to respond positively. Compassion, on the other hand, is about an awareness of suffering and a desire to alleviate it. So we get to the same place of trying to help people feel better, but it's actually because we're recognizing the suffering. It's not because we're skipping over it. And it's a much more lasting effect than if we just try to force people to be more positive or to be less negative about things. And so it actually requires courage to connect with people over their suffering, to be willing to connect about what's hard. And that is, again, that we actually connect better and more meaningfully about what's hard than about what's good. It's easy to connect when it's all sunshine and rainbows. It's scary and vulnerable to connect about the things that are not going well, the things that are scary, the things that you feel worried about. But connecting at that level is what can shift us out of that threat system and into the social engagement system. And so a few ways to do this, right? And, recognizing that, of course, if you're a healthcare provider, you're also trapped by the system and what it allows you to do. But our first step is actually just listening to what the person's experience is and what's hard and what's difficult and the suffering of it. This can feel exhausting also when we are dealing with someone with chronic pain, because it feels like we're never going to make this go away, right? And we can feel equally as helpless. But listening, and I often say you'll know you're listening if you're not talking, right? And often, just again, for lots of different reasons in medical visits, there's a checklist of stuff that we're trying to get through. And it often, lots of patients will walk out of their appointments and say, we didn't talk about anything I wanted to talk about. Now, it's not always possible to find time to listen, and having worked in healthcare for most of my career, I understand that. So sometimes it's even just saying, to patients, like, I really wish I could spend more time with you. I wish I had more time to listen to what's happening to you, and I should be able to, and I don't, because there's a long line of people after you. But I just want you to know that, I wish I could, and that's how it should be, that I would have enough time to listen to you. We do have the opportunity to listen to people, then we want to validate their experience. And I often remind people that validation ends in a period. It doesn't include a but. So we, again, sometimes rush to the problem solving a bit too quickly, right? So we might be talking about, like, I understand you're having this pain, but it looks like it's a bit better than last time, or, it looks like, but I think maybe we're making some progress, or, but we have another medication we can try. And the validation just ends in a period. And honestly, I encourage you to say the period out loud, right? It really sucks to have chronic pain, period. Period. It is really hard. It's exhausting, right? It is tapping your energy. It's using up that battery. It is really hard to have chronic pain, period. And we often worry that this is, going to make them wallow in that state and then we'll never get them out of it. But actually it's the thing that can shift people from that threat system to the social engagement system or the social safety system, which then actually allows them to be more open to new possibilities, to try new things. And you'll know kind of when people feel validated because then they sort of offer you the opposite, right? So often what happens, a classic example of this was like a couple I was working with and they were trying to validate each other. So the wife said, I'm really worried about money. Things are like really tight. I don't know what we're going to do. And the husband, very normally trying to calm his wife down, was like, no, it's okay. It's not that bad. We're going to be fine, which is, again, this thing we often do of trying to talk people down. But the response to that is, oh, you don't get it. And so let me explain to you how bad it is so that you can get it, right? And so she responded, no, it's really bad. Like we might lose the house. How are we going to send them to college? This is going to be terrible. And again, our natural response is to kind of like, no, it's going to be fine. It's not that bad. We're actually okay. And so then she ups the ante, right? Because again, we have this thing in our culture where you have to have a good reason for your feelings. And so if the person doesn't get it, you have to keep upping the ante until they finally get it from sort of an emotional perspective. The alternative, right, was that the wife said, it's really scary. We're going to run out of money. And the husband said, okay, I hear you. This is really scary. You're worried, that this is going to be really bad and might be terrible for us. There's a difference between validating someone's experience and validating their beliefs. He doesn't have to say, you're right, we're going to lose the house, but he's saying your experience of this is that you're terrified, you're really worried about this. And as he continued to say those things, at a certain point, she said, well, it's not that bad. It's not like we're going to lose the house. Right? And so that's when you know someone's been validated, is that they now offer you the opposite perspective. That's again that they have been shifted into this different state where now they can see different possibilities than the tunnel vision that they were in. We also then can just normalize the experience that feeling pain and feeling frustrated by it, feeling held back by it, feeling hopeless about it, catastrophizing it is all very normal human reactions, right? And actually, you're actually a well-functioning human if your pain system is working. So of course, there is a condition where people don't experience pain, and it is a disaster to try and keep those people alive. It is exceptionally difficult to keep children who don't have this system alive because they run on broken legs, they scratch their corneas out, they bleed internally and don't realize it. It is like a really huge problem for a human to not have this pain system. And so we're trying to normalize their experience, which is like, yes, people with chronic pain or chronic disease, this is exactly how they feel, period. It's just really hard, period. And then this is part of our ability to activate that social engagement system, is that they don't feel alone in this suffering, in this hardship that they're experiencing about chronic pain. They're not alone, that you are somebody with them in that moment. And that's sometimes like the best we can offer people, is simply to say like, you're not alone in this. Like we can work on this together. We can manage this together. You're not all by yourself and trying to fix this. And that again can be a very powerful experience for people to simply activate that social engagement system, and they feel better because they feel like they're not alone. They can see you being part of their village now. And I think it's also just really helpful to know that from the provider side, this also benefits the provider. So, for example, we did an intervention actually doing leadership training for burnout recovery. And one of the skills that we teach is about empathic styles. And this was because my colleague and I, Dr. Gillen, we got research money to study burnout in frontline workers during the pandemic. And having been a frontline worker during wave 1 and wave 2 of the pandemic, I was like, I'm not telling these people they just need to do more yoga. Like we are not telling frontline workers they just need to do more mindfulness and it'll all be okay. And so we actually tried to address the system level issues that cause burnout. And one of the system level issues you can target is leadership. And so we came up with a leadership program that was evidence-based, and then we demonstrated it had an effect through several pilot studies. And one of the skills we teach is about empathic styles. And this I really love because what this, again, well-validated kind of concept highlights is that there are different dimensions of empathy. That there is a perspective taking, which is sort of that cognitive, like logically, I can kind of understand what's happening. There's an empathic concern, which is again an emotional connection about understanding what it's like for the other person. But then there's also this personal distress, which is an alarm system where we sort of feel like we're experiencing the same threat as the person is. And then imagination is sort of the extent to which you can imagine these things, like how kind of vibrant it is for you to be in somebody else's shoes. And so it just amplifies the other subscales. But basically, healthcare providers are often sort of taught like you can't have feelings about it. You can't, you have to leave it at work. You can't bring it home with you. But this model suggests that actually the empathic concern dimension is actually protective against burnout. It's the personal distress subscale that is the risk factor for burnout. And often connecting with patients is the part that makes it worthwhile. It's a hard life being a healthcare worker, and even more so in this post pandemic world. And so, taking away those moments of connection is actually the part that makes the whole job worthwhile. And so I love this model because it gives healthcare providers an option. You don't have to just shut off all your feelings. And to me, this is just a hypothesis. I don't have any evidence for this. But that empathic concern is about connecting through the social engagement system. Personal distress is about connecting through the threat system. And so if we get caught up in the threat along with the patient, then we feel this same level of danger that they're feeling. But if we can connect over that through that social engagement system of just life is hard and this is suffering and let me be there with you in this moment of suffering, that's actually a protective factor against burnout. So it's also to say that these strategies we're talking about benefit the patient, but they actually benefit the healthcare provider too. So my last little point before I wrap up here is sort of how to have hope. Because frankly, in this post-apocalyptic world, it feels a little bit hopeless sometimes. And so there's one definition of hope, which is sort of about expecting a certain outcome or wanting a certain outcome to happen. But there's another definition of hope, which is the belief in possibilities, that there might be different solutions, different ways out of this, different things that we haven't even thought of that might address these problems. I think about that in terms of a chronic disease, in terms of chronic pain, but also like the healthcare system falling apart and, this like chaotic world we're now stuck in that, climate change, like if you want a certain outcome, I don't know if I can be hopeful about that, but I could have some belief in possibilities. There just might be things out there that we haven't even thought of, solutions that we don't even know yet that might actually bring about like something better in the future. And so maybe we can have that kind of hope, right? And again, we can think about all the things that have happened because of the pandemic that we never thought would have been possible. I know for sure virtual care working in the hospital was not something you were allowed to do. And now suddenly it is integrated in all kinds of ways of delivering healthcare. And so, these are some of the belief and possibilities that have already happened. Of course, we would like to have gotten there some other way than through the pandemic. But given that the pandemic happened, let's take the wins. So, whenever I'm working with somebody with chronic disease, I always say to them, it is entirely possible, and I know I'm convinced it can happen to help you live a meaningful and purposeful life. This chronic disease does not need to take that away from you. It might look different. It might not look the way you thought it was going to look. It might not feel the way you thought it was going to feel. And frankly, that's true for lots of us that our futures are not the things we thought they were going to be. But we definitely can help you live a meaningful and purposeful life. And that's really what pain interventions from a psychological perspective are aimed at, is they're helping people return to things that matter to them, even when the pain is there. And we can, again, make use of all that psychology and the way our brains work to sort of reduce the experience of pain through living a meaningful and purposeful life. And even if your pain doesn't go down, well, now you're doing things that matter to you. So at least you're living a vibrant life, even if you are still having pain. Because again, we won't necessarily be able to make that pain go away. But this is what we can offer, and again, is definitely possible as long as we're open to the fact that it might look different. And this is also kind of what I think we need to do to address pandemic burnout, which again, all of us are experiencing, especially healthcare workers. There's no frontal lobes anywhere. Okay, so I'll just wrap up here. So these are some additional resources. These are all books meant for the public that people can read that again are evidence-based interventions. So I also wrote a book about Healthy Habits Suck, which is really about trying to start and stick to healthy habits for chronic disease, but also, there's always things we could be doing to be healthy. Living Beyond Your Pain, again, acceptance and commitment therapy, all of these books are based on that. And it is one of, it's a well-established intervention for chronic pain and has some of the best support for treating chronic pain. And so these are all resources that your patients could read. We also offer therapy, both individual and group therapy to patients, and we have a chronic pain group that's coming up in January. We also do group interventions on other topics like healthy habits, sleep habits, binge eating, and we really prefer kind of partnering with clinics and organizations to help bring some psychology services that they might not have available to them. We offer group interventions because it reduces the cost per person and makes it more accessible. We run these virtually, and we, have people across Canada that participate in them. They typically are covered by extended benefits when patients have that, but also the group rate, helps reduce the cost per person. So that's our virtual health psychology clinic. Again, our what matters to us about that clinic, the values of the clinic are about trying to reduce human suffering, to bring people together, and to increase access to science-based information. So it's available to residents of Atlantic Canada, BC, Alberta, Ontario, and Quebec. We also specialize in treatment for healthcare providers. So in individual therapy, one of, probably about 85% of my caseload in individual therapy right now is physicians, residents, healthcare workers, just trying to cope with the current healthcare system and the burnout from the pandemic. And so again, having a lot of experience in the medical systems and knowing what that culture is like, it's part of the things we offer, as well as a real understanding of what healthcare providers are facing and trying to alleviate some of that suffering as well. We also do workplace interventions and training. So again, we have a trauma-informed leadership program, the burnout recovery training that I mentioned before. It's again a leadership program, mental fitness, diversity, equity, and inclusion. So we really see mental health in the workplace as a joint responsibility between employees and employers. And so we try to offer some of these system level interventions and employer interventions that can benefit everybody in the workplace and not just people kind of identified as being at risk. So that's really like a combination of those clinical psychology and workplace psychology skills to bring, again, evidence-based interventions. And again, we have a lot of expertise on our team. We have other psychologists that are all health psychologists, have all worked in the hospital systems for a long time. And so helping to create some healthcare system solutions as well about how do we fix healthcare. And again, maybe we can have the hope of possibilities that maybe as the healthcare system crumbles, maybe we can rebuild it into something better, something that is better suited for chronic disease, something that empowers patients more and doesn't put all of this burden, of compensating for the system on the shoulders of the healthcare providers. So that's my contact information. And so please feel free to contact me if you have questions or concerns. I'll also stop there and open it up for questions or comments.
Fantastic. Thank you so much for that presentation. I thought that was such a great mix of, evidence-based and research information, but also just kind of your personal experience. And yeah, I think there was something in there for everybody. So I'll just encourage people who have questions to put your questions in the Q&A box, and then we will try to get to as many as possible in the remaining 12 minutes. So the first question someone had was just about the groups that you mentioned. They asked, are the groups open to youth, so that specifically ages 13 to 19?
Yeah, so I'm licensed as an adult psychologist, so there's kind of a lower limit. I can sort of do kind of high school age students if they're kind of mature minors. And so, high school 16, 17 is about as low as we go as adult psychologists.
Mhm.
And so it would be eligible for those individuals. And I mean, I also sort of agree that there are like some real deficits in mental health for adolescents as well. So we do also treat parents, right? So if parents are struggling with their teenagers or their child who has a chronic disease, we do support parents in that way too.
Okay, great. So I had a question that I'll ask while we wait for some more to come in. Um, so for yourself, where do you tend to go for kind of the latest like evidence-based information, or do you have any recommendations for healthcare providers who are wanting to, learn more about these topics? Where would you send them?
Yeah, I mean, I really think that, again, one of the things that would be great to change about our healthcare system is to have more multidisciplinary teams so that you can rely on the expertise of other disciplines who are
Mhm.
great with that kind of information. It would be daunting to try to figure out all of this, the psychological literature, if for anyone, even for the psychologist. But tapping into these different skill sets that different people have, I think is a really helpful way of treating individuals. And so that's honestly like the best case scenario, that you connect with other multidisciplinary team members so that there is a way to make use of those separate kind of education and expertise so that you don't have to feel like you're doing it all. It can be just a warm handoff to your colleague to help make use of their skill set.
Okay. This person had the same question as me. Okay, they say, hi there, I'm a trauma therapist, and I'm wondering if you can speak a little bit about trauma and the incidence of chronic pain and how to treat that.
Yeah, for sure. So, I mean, some of the things we talked about today, including kind of that threat system and polyvagal theory, are the kinds of things that we do to treat trauma as well. It's the same system, right? It's that threat system and that survival brain that is both being activated by trauma and being activated by the pain, like your pain system. It's the same kind of system, and so we know these things go together. If you have had a lot of trauma, your system is designed to be have a lower threshold for danger, to be on alert. Some of the symptoms we describe in PTSD are actually totally adaptive in another context. If you have been attacked by a bear, then having flashbacks about how you got away from the bear attack, being hyper vigilant about where bears might be, that actually could save your life. And so it's that system just trying to protect people. It just happens to be a real mismatch with the kinds of threats and traumas we tend to deal with in our modern world. But again, it's not a faulty system. And so, again, there are treatments for trauma that are going to also try to activate that social engagement system to help people get out of that threat system. What we really like about some of our trauma informed leadership training is, how do you create a workplace that actually is less triggering to people? So again, there is the intervention for the person that we want to have available, but we could also make workplaces that are trauma informed, that are creating environments where that social engagement system has been activated, where people are less triggered, where it's a safer environment. And then you're helping a whole bunch of people, we really think that there's a lot more people who will have experienced trauma because of living through the pandemic. There are lots of aspects of that that fit into the experience of trauma, and definitely for healthcare workers too. So again, we'd like to create, environments that are more conducive to coping with those trauma responses and keeping people in that social engagement system. But the treatments for individuals are going to make use of both for pain and trauma.
Great, thank you. Next question is, do you use any apps or technology to help with building healthy routines, etc.? And do you have any that you can recommend?
Yeah, so I mean, I definitely think that there are apps in terms of sort of mindfulness practices, is where I think the apps have really done well. So Like we're doing a sleep program and we recommend like the Calm app, for example, or Headspace, because they have really well-developed meditations, but also sleep stories and like sleep meditations. And so I think those apps are really great for addressing mindfulness skills or relaxation skills. We do have an app that we use on our team, but it's not kind of publicly available. We do it as part of either group interventions or coaching programs, both for healthcare providers and for patients. And it's really about like mental fitness, and it really emphasizes practicing those skills and sort of building a mental muscle in the same way that you would build muscle memory for like a tennis swing. How do you build muscle memory to kind of keep your wise mind engaged, keep your frontal lobe engaged versus having your survival mind in charge? And so it has a lot of ways to practice those kind of self-command muscles to make them stronger and better able to handle things, which results in behavior change. If you contact me, I'm certainly happy to give more information about that. It's not a publicly available app, but it's by far the best app we've ever seen for kind of behavior change and emphasizing that behavior change.
Okay. Another question about an app. Do you have any thoughts on the Curable app? Have you come across it, or have you implemented it at all?
No, I don't know about it, so I can't comment on it. So apologies.
No worries. Um, okay. And someone who is a care aid educator, they're asking where can they go to get training about pain so that they can coach care aides who work in care homes. They say that a lot of responsive behavior in the elderly is caused by pain.
Yeah, so to be honest, I don't have a great recommendation. I think these are kind of the training things that lots of healthcare providers are looking for, which is probably exactly why you have this webinar here aimed at healthcare providers, because it is kind of a difficult thing to access. We do training for healthcare providers. It's something we've done for a long time about psychological factors that they can implement within their scope of practice to help with behavior change, to help with chronic disease management. So we do have some of those kinds of training available through our clinic, but it is definitely the kind of like, again, if I was going to redesign healthcare, there would be a lot more psychological training for all of the healthcare providers in terms of how to deal with, psychological factors. Because again, it's the thing that causes the most problems, really, right? Again, lots of people don't follow their medical recommendations. They're not doing the things we told them to do. And this is really common. Like some statistics say 70% of people are not following their medical recommendations for chronic disease management. And so there will never be enough psychologists to address that, nor do they show up for appointments. If you send somebody who's non-compliant to the psychologist, they don't show up. Right. But embedding those skills in other healthcare providers so that everybody has those skills to help with behavior change and chronic disease management, I think is definitely something that's needed. And it's often the thing that patients talk about, right? That they are distressed about the psychosocial factors, the emotional consequences. And really, healthcare providers don't have many skills to deal with that. And so it's very understandable that they kind of don't want to open a can of worms that they can't solve. We offer interventions for patients, but, we would much rather, again, address the system by building capacity in the system to deal with, have these kinds of skill sets for all healthcare providers.
Totally, I agree. And I think, we work in the field of healthcare education as well. And I think that, as you said, that like 70%, I think that, maybe the different way to go about it is, figuring out, treatment recommendations that are a better fit for the person, right? As opposed to kind of making a patient kind of like fit within a pre-existing mold that doesn't work for them. I will also just say, as a shameless plug, Pain BC does offer online courses for healthcare providers in pain management. So if you're outside of BC, they are available for a fee, but within BC, all healthcare providers, you can access it for free. We have one that's aimed at allied health and one that's for primary care. So please do check out our website. if you want to learn more.
Absolutely. Yeah. And again, chronic disease management is not well done because, again, most of the work to manage a chronic disease actually happens outside of the hospital. It happens outside of the clinic. And so you need a totally different kind of buy-in, right, by a patient who's actually going to do all the work. And so that's what behavior change skills are about, is how do you come up with something that actually fits their life, that fits, which might not be the same as what's on our agenda. And that's what can be hard as a healthcare provider, because we're again trained to kind of be the experts, be in charge, but it's a terrible model for chronic disease. Just doesn't really make any sense. So yeah, and definitely take advantage of like online training like this. That's a really, a big gift that you can access that.
All right, so we have 1 minute left, so maybe one more question if anyone wants to sneak one in there. Otherwise, just wait a couple seconds, see.
You always have to give people time to type so you don't know.
Just thank yous coming in. People are saying excellent presentation, big thank you. Yeah, okay, so we'll call it there. So thank you everyone so much for if you're in BC, joining us during your lunch break today, or maybe in the middle of your workday. Really appreciate you spending time with us and for all of your great questions. Thank you again, Dr. Lee-Baggley, for this excellent presentation. I think everyone will be looking forward to the recording as well. And please do, use those resources and get in touch if you think it'll be a fit. And we'll see you for the next webinar in November.
Thank you. Have a great day, everybody.
Thank you. Take care.